Wednesday. Welcome. Good morning, friends. Today we are gathered for the very first Disability Without Poverty Symposium, learning from today to make tomorrow better. We also want to acknowledge this is our third annual Disability Without Poverty report card as well. So we welcome all members, allies, supporters, professionals of service providers, researchers, and community members who are gathered on virtual today. It is my honor to give my opening welcoming to you all. I ask of you that today is, as we know, December 3rd. It is the International Disability Day. The United Nations had announced that the theme is Fostering Disability Inclusive Society for Advancing Social Progress. Furthermore to saying to that, let's be sure that today we keep our hearts open, our mind open, and that we listen, and that we will walk away with a wealth of information. I am very grateful and thankful for the staff of Disability Without Poverty for making this event possible for us to be on Zoom virtually. So I wish you all the best, and I know that we can make a difference in this community by helping, sharing, learning, understanding, empathizing with one another, and showing compassion as activists. All for now. Hi, all my relations.
Good morning, and thank you, Sandra, for that beautiful blessing and welcome. Hello, Symposium goers. Welcome. My name is Sabrina, and it is an honor to be your host today on Stream B. Before we begin, as our viewers log on, please take a moment to select your language preference. If you encounter any issues, please send a note in our chat, and our team will help as best as we can. At this time, I'd like to introduce our first panel, and it is a conversation between Dr. Jen Rinaldi and Dr. Heather Shearer, both of Toronto Tech University, as they present a body of work called Locating Legislated Poverty in the Structuring of Ontario's Disability Service Provisions. Over to you, Dr. Rinaldi.
Thank you so much, Sabrina. Hi, everyone. I'm just going to share slides. That worked. We're good. Okay. My name is Jen Rinaldi. I'm joining you from the traditional territories of the Mississaugas of the Credit, Anishinaabeg, Chippewa, Haudenosaunee, and Wendat peoples. For a visual description, I'm a white woman with glasses and short brown hair. I'm wearing red today. The scarf is a little loud, so maybe it won't last. My background's a white wall with some Christmas tree decorations. My presentation slides will include visuals, but none relevant to the project itself, just images of community activities or building and repairing homes. I'm an associate professor in legal studies at Ontario Tech University with a background in disability studies. I come to disability research as someone who has a history moving in and out of psychiatric diagnosis, and I encounter disability in relation through advocacy and collaboration with institutionalized and incarcerated populations. I'm starting today's panel on legislated disability poverty with a presentation titled Turbulent Institutional Legacies, Disability Support Workers Contemplate the Neoliberalization of Disability Supports, and then I'll turn over to my colleague. I'm here on behalf of my research collaborators, Siobhan Saravanamutu, a political science doctoral candidate at York University, and Kate Rossiter, professor in health studies at Wilfrid Laurier University. Just checking the chat to make sure I'm not going too fast. Okay. They both co-drafted this presentation. The script is an adaptation of a book chapter currently under review. My bio is entwined with theirs, representing over 10 years of studying the conditions endemic to total institutionalization that generate violence, and we work towards deinstitutionalization and abolition. Typically, that work is survivor-centric, but the SSHRC-funded project that yielded data for this presentation entails consulting with community living service providers in a partnership with a local agency. I wonder how the slides, there we go. The state provision of care for disabled people has a long fraught history at the mercy of economic and political pressures and sectoral change that is not always aligned with disabled people's needs and calls to action. This paper draws on the perspectives of disability support workers to describe the current state of crisis within disability care systems as the Ontario government moves away from funding social service agencies towards an individualized funding model. We work directly with a community living agency to explore concerns that disability support workers have with funding model reforms, specifically whether those reforms address or sustain the crises of financial precarity that intellectually disabled people experience. So state-level care for people labeled as having an intellectual disability has an overwhelmingly ugly history. It's tied to both the growth of the state as an apparatus of population-level organization and control, and the medicalization of disabled people, such that disability care in Ontario has its roots in state-funded, state-run institutional facilities such as sanatoria, asylums, hospital schools, designed to warehouse people, sometimes across their whole lives. Relying on an austerity ideology, these institutions were sites of material deprivation and neglect. They also kept disabled people away from the general public, were rife with physical, emotional, and sexual abuse, acting as both product and productive of dehumanization. When public concerns about the state of institutional care emerged as early as the 1960s, North America's deinstitutionalization movement led to sector-wide reorganization of public resources. It was slow and reluctant work, particularly for intellectually disabled populations, as the survivors we first worked with had histories tied to an institution that only shuttered its doors as recently as 2009. But I'm describing a transition to community-based provisioning of social supports, which could have worked, is absolutely the goal my team endorses and advocates for. We don't like institutions. If only it had not occurred within the context of the neoliberal rollback of public programming more broadly, acting as a real limit to political imagination and policy design. Neoliberalism's impact on disability policy is borne out in the limited patchwork of public support and the operation of many state-funded services for disabled people offered by community-based nonprofit organizations, including community living agencies. In terms of disability policy, the state's level of responsibility for provisioning for intellectually disabled people has not experienced so much as a transition of locale from institution to community. It seems more like alongside deinstitutionalization, there's been a corresponding ratcheting up of the responsibilization of care in the private sphere of the household. What supports for living in community looks like in the context of Ontario is so much always ever in flux. It's responsive to a range of political pressures. Many disabled people and their families have pushed for the current shift to individualized funding of disability service work, seen as a model which enables greater agency in terms of organizing and choosing support staff. Ontario enabled adults and their caregivers to apply to receive direct supports, for instance, from community agencies that have provincial government funding, and this paved the way for introducing a passport funding program in 2014, currently in place. What's up, Heather?
I just want to let you know you're on you just switched slides.
I do this to my students all the time. Is that what you're suggesting? Yeah, thank you. I need you.
Okay.
I'll never follow my slides with great fidelity. Okay, so we are talking about passport program funding. It's available to adults eligible for other developmental service funding. It's used to support recipients' activities of daily life, person-directed planning, caregiver respite, and participation in community. It's a program that's distinct from disability income support that's designed to supplement. It, of course, still means that intellectually disabled people continue to fall under the provincial poverty line. In 2021, this is the most recent and in-process transition. The Ministry of Community and Social Services adopted its long-term Journey to Belonging plan under an omnibus bill to reform developmental service offerings. Its timeline entails an implementation and transition phase that they're undergoing right now. There's going to be a full provincial rollout 2027 through 2031. And this plan proposes to amend legislation to allow the ministry to gradually introduce a new direct funding model, a model that expands the direct funding arrangement originally piloted in the passport program. The restructured funding model is described in ministry reporting as person-centered. It's geared toward innovation, or to use the language from reporting. It has performance metrics to improve accountability. A person-centered approach in this instance, like really lovely language, but it does mean that funds are sent directly in annual lump sums to recipients to be managed by them or their families, varying person to person based on needs assessments. Direct funding has its proponents, certainly, in disability activism, and I acknowledge that while I usually work with disabled people, I'm about to share the perspectives of people employed at an agency that has a vested interest in the previous funding model, as well as its own history linked to institutional models. Some of the staff we interviewed used to work at now and only recently closed institutions, and community living, born largely of a parental movement, has produced sheltered workshops and congregate living in group homes. But I do want to raise for this presentation that direct funding models have been criticized for yielding to an unregulated marketization of disability support services. So if we look to OPSU, a union representing disability support workers, they report that family lobbying for direct funding is prompted by a prolonged chronic underfunding and fragmentation of services triggered by decades-long crisis for individuals who need services and housing. That's all entirely understandable. Those are problems we need to fix. And yet they caution there is no ready marketplace of services to absorb the demands for programs in residential housing. So in this vacuum, OPSU predicts that the funding model will produce a parallel for-profit system and will compete with already underfunded public services. This brings me to a SSHRC-funded project I am presenting today that entailed partnering with a Southern Ontario community living chapter. We recruited 14 frontline workers. All study participants worked for the partner agency for quite a few years. Their tenure of employment ranged from 17 to 39 years. All participants were women, which coincides with the historical trend towards feminization of care work. The care provisioning has historically been constituted as natural and universal work for women and is correspondingly undervalued. Participants were homogenous in another way that was more peculiar. They were all white, which contradicts trends in support service sectors like this. Racialized workers, often newcomers, disproportionately represent this workforce. It's an intersectional consideration that prompts efforts from scholars like Mary Jean Hand and Christine Kelly to theorize versions of justice that work for all participants in care-based service relations, both workers and care recipients. But the racial makeup of our participant population reflected the staff complement of an agency located in a majority white small town. We're also looking for something specific in this particular project that's less relevant to today's presentation. We were looking at people who specifically worked with class action settlement claims, so they tended to be more senior in the organization. From November 2024 through April 25, our team ran in-person on-site focus groups and individual meetings when they were requested with our participant population. That included 10 frontline service workers, 3 supervisors, and 1 upper administration, though we kept people in different roles and different focus groups. We ran 3 separate phases of focus groups, each with a different semi-structured script focused on a different aspect to community living work. So participants were invited to all 3 focus groups in order to sort of build rapport with our interviewers, to expand on their thoughts about disability service work and the challenges they encounter. And most participants did wind up attending all 3. So we ran 10 focus groups and 6 interviews in total, and sessions were recorded and transcribed. Pseudonyms were attached to participants. I use a few in the quotes I'm about to deliver. I'll share some findings that we have been contemplating through our very preliminary thematic analysis of transcripts. And it's revolving around disability support workers speaking to concerns they have with the structural violences, the ways in which current funding models tend to legislate and re-entrench impoverishment. So the frontline staff participating in our study report on implications to direct funding, a model that purports to be person-centered in ways that expand choice, but that has the effect of typically scaling back available supports. While Developmental Services Ontario can still direct recipient funds to the agency that's managing DSW labor, all or some funds are now sent directly to recipients in these giant lump sums for managing one's own hiring. And that expands choice. It does change what community living does. Workers accommodate this mix by billing clients directly for their hours, rather than just like being tasked with providing the service. And so participants in the study referenced how quickly their allotted hours, amounting to $5,500 per year, would bleed away when supporting social activities. They talk about anything that we can do, anything we do for disabled people can be billed now, and that is real limiting in the $5,500 that they're allotted. So Lynn, for example, explained that for one person she supports, his most pressing needs are met via strained family support to sort of make up for what she can provide. I'll quote her at length. Journey to belonging, from my understanding, is that the person will prove how much support they're going to need. So that gentleman I was referring to, he needs a lot more one-on-one. So now he has lump sum funding he can put towards his day programs, but he'd only get $5,500 from my support, and his sister manages the rest of his care. And that was a real struggle because his sister works full-time. Participants were quick to point out that the funding provided is insufficient for clients who already live below the poverty line, that it has not done enough to supplement efforts to lift disabled people out of poverty. Housing in particular is a crisis point for intellectually disabled people in the province, which means that disability support workers may come into their work with the mandate to support community integration, but they can't get past that baseline hurdle of in trying to work at the problem of housing precarity. I'll quote Stephanie here. Some in my caseload are unhoused. So it's hard to meet goals when I'm in there for only 2 hours, when I'm fighting with ODSP and housing for the 2 hours I'm given. I can't help them go to a concert or do something they want to do when they have no place to live. And this is Carmen, due to passport funding limitations and journey to belonging complications. You can have a TV, but you're living in a tent. You can go to the movies, but you can't buy food. So direct funding hasn't advanced community living goals, much less been solving these crises. Instead, community living services are limited now to these billable hours and then exhausted on crisis management. Our partnering agency has taken seriously the need to counter larger forces that operate against clients' best interests or that replicate harmful dynamics of institutionalized care, such as sheltered workshops and group homes from community living histories. In particular, this chapter we were working with has undertaken a great deal of effort to reduce its group home living facilities. They're no longer accepting new bed placements with a goal of replacing group homes with supported housing arrangements for all of their client base, for lack of a better word, people who have housing support needs. And this is because group homes, a staple approach since the transition from institutional care to living in community, they're widely criticized for their similarities to institutional life on a smaller scale, like the potential for regimentation of daily living and deprivations of privacy and agency. So People First Canada has cautioned, and I'll quote them, an institution is not defined merely by its size. The organization means that facilities can operate as institutions, just on a smaller scale, as long as they segregate or congregate disabled people and restrict their control over day-to-day decisions. But as an organization that relies on state funding for much of its operation and service provisions, community living is beholden to the limits of funding design in much of its operational decisions. So Journey to Belonging is enabling a marketization of developmental service provision that can afford to offer more service, more variety, because workers may not be unionized, may work for lower wages, may have to work for lower wages because they don't have a choice. And an unregulated private alternative might not take responsibility for the needs of the people they're supporting. I'll quote one participant. At the same time these dollars are being spent on, say, concerts, it's the meaningful things that are going to sustain clients that are getting lost. And here's Natalie at length. Whether we stay involved in support provision depends on what each person will get and if they choose to stay with us as a service provider. Clients could go to private supports and never have anybody to help with all the things that actually matter, medical appointments, housing, financial supports. We're currently supporting people in that capacity through all programs if that is something they require, whereas if you just have a lump sum and you go somewhere private, you might not get that support. And so the participants in our study talked about how aging, impoverished, and unhoused people they support have increasingly encountered limitations to their options, where service provisions available to them resemble old institutional models. Private services lack the regulatory oversight of a publicly funded third sector, and profit-driven agencies are going to be leaning in the direction of austerity or efficiency models to manage care. There's even the risk that families themselves, if they can't find housing and they have piles of money to figure out what to do with, sometimes they go in on their own boarding home, their own established group home. So we're reinventing institutions through the direct funding model. There were several examples given by our participant group, talking about a 12-bedroom home, privately run, that some of their clients live in, 35-bedroom group home, again, privately run. These options are made available as alternatives when publicly funded supports prove insufficient or too high a cost. I'm probably out of time. The management of state-funded policy provisioning for intellectually disabled people has long been characterized by turbulence, and we find that this continues in the contemporary moment. The movement towards individualized funding relating to the management of care supports offered by the Ontario government, it has promise. I understand it's advocated for in disability community, but it has been shown in the way it has currently structured to lead to privatization of care and a re-entrenchment of an institutional ethos. So I'll leave it there, and I'll turn things over to my colleague, Dr. Heather Shearer.
Thanks so much, Jen.
I can introduce, if you want, a clinical epidemiologist and chiropractor, a director of the Department of Clinical and Health Services Research at the Canadian Memorial Chiropractic College. She's an associate professor at Ontario Tech University and a scientist at the Institute for Disability and Rehabilitation Research. She also works at Holland Bloorview Kids Rehabilitation Hospital. She conducts pediatric disability and rehabilitation research there. And if Heather will allow, she's the mother of twin teenage boys with cerebral palsy. So the birth of her children and subsequent diagnoses and her role as advocate for their health, well-being, and education fuels her passion for disability research. Take it away, Heather.
Thanks, Jen. I hope you can all see my slides here. Are they in presenter mode, Jen?
Yes.
Perfect. Okay. So I'm just going to click over here. And as a visual description, I am a white female, middle-aged, wearing blue glasses with sandy blonde wavy hair. I'm currently in my office with a blurred background. So today I'm really pleased to be able to come and present at this symposium about research I did. And I just want to mention the co-investigators I've worked with. So Drs. Pierre Cote, Taryn Eckmeyer, Dan Wang, Mr. Andrew Marsden, and Miss Simran Walia, who is an undergrad student who I worked with. And this work is really looking at access to care among children with neurodevelopmental disabilities in the Durham region. And so that's a region east of the Greater Toronto region. So it spans kind of a long, narrow area north to west of Toronto, or north to south of Toronto, just above Lake Ontario. Well, so for any of you who have children with developmental disabilities, or you care for them, or you happen to be familiar with some of the news stories, over the past few years, and especially since COVID, there have been a lot of reports about delayed access to care. And this isn't specific to just children, but also to adults as well. So what I focused on with this research is access to care for children with developmental disorders in the Durham region. And there are lots of reports that have come out and work is being done to help improve this because there are a lot of different implications related to delayed care. So for example, some children, especially younger children, can miss important milestones, and this is cognitive, emotional, mental, and physical. There are major financial constraints that happen with this if children are not getting care early. And then also it can cause quite a bit of family stress, not only for the parent, but for the child, and then also for caregivers. So in terms of the local relevance, in Ontario, and actually right across Canada, for children who are diagnosed with developmental disorders, they're treated at what are called children's treatment centers. And these are government-funded treatment centers for children with neurodevelopmental and neurodisabilities. And so there's 21 of these government-funded agencies in Ontario. And so Grandview Kids is the agency that services Durham region. And they'll typically cover services such as physiotherapy, speech therapy, occupational therapy, There's some social work programs that go along with this, and a variety of recreational services as well. The issue is that in the past 10 years or so, the wait list has increased exponentially for the services there. So currently, for the core clinical services, and I'll refer to those as the core services, so physiotherapy, speech therapy, and occupational therapy, there's a wait list of around 5,500 children. And this ranged, it increased, especially after COVID. But in 2021, what happened was these treatment centers also took on care that children are receiving in schools. So this is in primary and secondary schools. And the wait list ballooned up to 16,000 if we include those numbers in the service provision as well. So we wanted to look at how much wait lists changed, looking at the data that Grandview collects themselves. So we had a couple of different study objectives. The first one was to identify how feasible it is to actually measure these changes in access to care at Grandview using their electronic health record system. Next, we wanted to look at the change in access to care over the years, so from 2012 to 2023. And then finally, once we had all this data, I actually went and presented it to clinicians and staff at Grandview to get their perspective, because it's one thing to have this information, but then we have to start to get a sense of what are we going to do with it, who can provide input, so not only families, but clinicians, and then of course, government, because this access to care is all tied into policy regulations around service provision and financial support for these services. So this was an exploratory pilot study of historical data, so data that existed in the health records. We sampled children who were 0 to 21 years old. They had to be Grandview Kids clients, and they had to access those core rehabilitation services. So again, physiotherapy, occupational therapy, and speech therapy. We used the electronic health records and we looked at specific items. So when they were referred, what their birth year was, what program they accessed, where they were referred from. So was it from their family doctor, another hospital, so forth, or they could even self-refer, their sex, and their postal code. So we were a bit limited in the information that we could capture from these charts or the health records, but we used what we could to inform this study. So when we look at the feasibility indicators, so these are markers of feasibility, we found that for the processes, so to be able to access the information, it was pretty easy. We got a lot of help from our partner, Grandview Kids. It was easy to transfer the information to the university so we could analyze it. And we were able to match the inclusion criteria for this study pretty well to what was included in the health records. In terms of our resources, so really if you think about these as time to do the study and budget to do the study, this worked out well. This type of study isn't too intensive in that way, especially if you don't have a lot of data to work with, which we didn't per se. So it did require specialized service, so IT services from Grandview Kids. They had to cut the data sets, and there were some time limitations because they actually switched health record systems. So that's why we had to end in 2023 with that data and not go further. And then there were some challenges. So this is why I have a big red X on the screen above this box around some of the management issues. So as I said, they started a new electronic health record system in November of 2023. We could not access the actual diagnoses of the children in the charts. that's a text box, so it makes it very hard and labor intensive to go through that information, versus it being, let's say, a checkbox or a drop-down menu that people could pick. So let's say they could pick cerebral palsy or autism, and then, have secondary diagnosis. And there weren't always very clearly defined treatment dates. So what I mean by this is we always had the date when the referral came into Grandview Kids, but we didn't always have the date where they actually received care. So sometimes it was recorded as a phone call. So it could be the admin staff contacting the family saying, oh, we're booking you in, versus the date that they actually start treatment. So they weren't systematically recording it in a standardized way. And that's a limitation that they have hopefully fixed with the new electronic health system based on the results of this study. So to give you an overview of the clients at Grandview within this data, we had just over 24,000 clients in the data cut that we had, and that comprised over 400,000 visits between those three services. The age category, so 95% of the kiddos in this data set were 0 to 5 years old. 66% were male, and that goes along with a lot of these neurodevelopmental disorders. They tend to be more prevalent or more common in boys than girls. And then in terms of the areas of residence, you can see on the table here, I've just listed them by the most common, so Oshawa, where the main hub for Grandview Kids is located, had the highest number of attendees. Ajax, Whitby, Pickering, those were kind of next in order. And then some of the smaller communities around those locations followed in next. It actually covers a lot more regions than this, but I only included those that had over 2% attending Grandview. There are quite a number of different areas serviced by Grandview Kids. So I have a table here, and I've put red boxes around it, and I'll just walk you through to describe what we're seeing here. So in the left-hand column are the different programs provided by Grandview. So again, there's speech, which is SLP, occupational therapy, which is OT, and PT or physiotherapy. And we broke them up into the age categories in which they're serviced. So there's the preschool age, and only speech provides services in preschool age. So at the age of 6, children age out of that program, and they then have to pay for that out of pocket, unless it's covered under the, let's say, the autism program in Ontario. But for children who don't have autism, then it's an out-of-pocket service if they have coverage for the autism program, which we know many don't. And then there's the school-age children, and then adolescents. So once you hit 13 to 21, you fall into this adolescent group. And the reason why we did this is that the kiddos transition between different therapists, and that can affect wait times between each of these age groups. So the middle box here shows the median wait time. So instead of doing average, we did a median because the data is a little bit skewed, so it kind of shifts to one side. So this is a better way of reporting it. And kind of some of the prominent numbers. So for the teenagers who received occupational therapy, they had a median wait time of 233 days. So kind of 3/4 of a year to get seen. So that's not necessarily starting care, that's just for maybe their initial assessment. And the lowest wait time was actually among the school-age preschool kiddos. And this makes sense because there's a big push to get those kids through their services because they age out quickly. And then when we look at maximum wait times, which is the last column in this table, the numbers are pretty, all I can say is scary as a mom of children who receives these services. The minimum wait time that's reported is for speech it's over 1,800 days. And then the maximum wait time, again, was for occupational therapy, and that's for the school-age kids, which was 2,700 days. And we dug into this a little bit more because I was so shocked by these numbers. And what we found is when the children actually reached those high numbers, they didn't actually receive care. They aged out of the system and were kind of cut out of therapy services. So they were no longer eligible for care either within that program, and they had to go into adult services or get private services as their only option. So I'm just going to show you a visual here. And this table shows if we were to break the data into 4 quarters, I'm showing you the third quartile here. So those who had the longest wait time, kind of that last quarter, and it's broken down by the number of kiddos in each of those age groups. And what this really represents is that there are 22, if you picture a large yellow school bus that, holds 50 some odd kids, there's 22 full school buses of kids just in that quarter waiting for services within all these programs. So that's always a visual that I like to think about because it really puts it in, it's one thing to see all these numbers, but when you think of 22 large school buses of kids waiting for care, and that's not all the kids, those are just the ones who waited the longest, it's pretty sad. So this graph is a little bit complicated, so I'll do my best to walk you through it. But what this shows are the wait times by year for all the kids. So each colored line is a different year, or we call it a cohort. But I'll just call it a different year. And then we have this dotted line here. I hope you can see my cursor, which is at about the 50% mark and at about 6 months. So it's that intersection between the 2 points. And so what this is showing is that about 45% of the children who attend Grandview wait an average of 6 months before they're seen for services. And again, this doesn't necessarily mean that at 6 months they're getting care. It means at 6 months they're getting picked up. So they might get an assessment and then have to wait longer before their care starts because the clinicians are booked so fully that they can't fit them into their schedule yet. And they have to wait for a spot to open. And there's a lot of different reasons for this. It can be lack of funding for healthcare providers. It can be a lack of spots available, certain times of the day that are priorities. So a lot of these children have appointments with specialists, so they get pulled from school quite frequently. So when they receive these core services, they tend to like to book them after school so that they're missing less school. And so that's a premium time, and a lot of families, they just can't afford for their children to keep missing school, so they'll refuse services or wait for service spots to open after school hours. So we did have a grad student. She's currently a grad student now, but when she helped with this project, she was an undergraduate student, Simran Walia. She got some government funding to help with this project. And then what she's actually gone on to do with her project is to look at other factors. And so we're analyzing that data now. So that will be kind of the next step. But she's looking at gender, referral source, neighborhoods where individuals live, and I'll talk about that briefly regarding implications, and age for these kids, whether that makes a difference in terms of access to care. So we got this data and we thought, okay, what now? We need to consider the various perspectives, like I said previously. So I went to the clinicians. We had a clinician day where I went and got their perspectives. And we did a bit of a brainstorming session where we engaged them and asked them to share their experiences with the challenges of their clients accessing care. So we had 6 questions, and I'm just going to go through a couple of the quotes that were provided that day. So we asked, what are you hearing from your clients related to wait times for these core services at Grandview? and they report the families are saying they're waiting forever. They're often asked about private services because they don't want to wait for the funded services. Some families are saying it's too long and there's not enough service provided once they do get in. Some families are quite frustrated, and one person reported saying they said it was disgusting, ridiculous, laughable, and you can think of the other expletives that would go along with this. And other people report the wait list itself isn't long, but the time between appointments is long. So what they'll do is they'll put you in a block, but they spread out appointments in a block of, let's say, 8 appointments so that you have a longer period of care. But the time between those appointments could be 2 weeks, sometimes 3 weeks. The second question we asked was, have the wait times impacted the care you provide to your clients? And again, it's these 3 core services. Some said not at all, and these are summaries. We kind of grouped the findings together. They were worried that the care they provide really focuses on discharge because they have such a short amount of time with these kids that they're just focusing on getting through a program to be able to discharge them and give them services that they can do on their own. It's reduced, they've seen a reduction in the number of sessions they can provide. It limits the impact of early intervention, and often with this clientele, the big push is to have them treated as early as possible. It increases fatigue and burnout of those who are caring for these families and kids, because they not only have to deal with, the very complex conditions of these children, but also all these frustrations that they feel and the families feel, and they're frustrated with the system as well. And then they say families report that by the time they get to care, the child has missed a critical period, and it actually takes longer for them to achieve their goals, if they do at all, than if they had started earlier. And then the third question was, what's your perspective on how a change to a tiered delivery system in Ontario has changed wait times or access to care? So what they do is they'll go into the school system. Tier 1 is they kind of do a scan of everybody in a class and provide general services. This is tier 1, and leave it to the teacher or an EA in the class to help with handwriting skills. So instead of them getting referred to an OT, that happens. So it's kind of general skills. And then tier 2 is they would need more advanced service, and tier 3 is typically children with fairly significant needs who need quite specialized services and often end up being seen by more than one care provider. So some say it's too soon to tell. It puts a lot of pressure on the parents and caregivers to provide care because they're not getting into the higher tiers. Their kiddos aren't getting into there. It decreases some wait times because not all these children are getting referred in anymore. Some say it's helped immensely. There are concerns regarding equity into who falls into what tiers. And the tier 1 service is equivalent to no service. And this is a program that the government actually initiated to reduce wait times. And so it's still kind of working through the system to see how effective this actually is. And then we just wanted to gather perspectives on what they think could help. So here's just a thought cloud where they said the biggest comment was they wanted more clinicians, care pathways, increased clinical staff, more virtual sessions, additional support pathways, and increased direct hours. So those were some of the comments. And then some of the biggest challenges, concerns to wait times is their clients can't afford private services, the impact on clinical outcomes, client satisfaction, minimal time for care, as we've heard, this is a recurrent theme, and they wait so long for care that they're no longer eligible. And we did find that supported with the data. And I know we're out of time, so I'm just going to pass through these last ones and put my last screen up. But if anybody has questions or wants to chat more about this, I'm more than happy to be contacted and talk about this data, because there is a lot to unpack here, and we're still just working through it. So thank you.
Thank you, Dr. Shearer. And Dr. Rinaldi, I actually did receive 2 questions, but I know we are out of time. We will definitely send the questions to you, and we would love to hear your responses. So at this time, I would like to thank both Dr. Rinaldi and Dr. Shearer for their time. And it has been a very engaging and insightful conversation. And we hope their viewers enjoyed the panel. So we'd like to just now take a 10-minute break and thank the viewers, and stay tuned, and we'll see you in 10. Thank you.